We thought we'd end neuroscience review with a brief practice exam. The point of this is to use imaging to demonstrate neurologic signs and symptoms and tie them to specific neurologic conditions. So, because of the prevalence of neuroscience exam questions, we thought this might be a valuable additional resource to a neuroscience review. All right, so starting off, first thing you want to do when you see any image that appears on your computer screen is recognize where you are, because obviously that could be relevant and could be a participating factor in the answer. So what we're looking at is a Nissl-stained view of a spinal cord section that's stained with a Nissl stain. Our first task is to identify generally where the spinal cord section is from, because where it is may have some impact on the answer choice. Certainly, we're looking at an area of the spinal cord that has a very large ventral horn, which is characteristic either of the cervical enlargement or the lumbosacral enlargement. And since there is only one obvious dorsal column in conjunction with that large ventral horn, we have to assume this is probably in the lumbosacral enlargement, which is our best guess. So most likely, because of the thinness of the white matter in this section, it's probably at lower lumbar cord levels. All right, so the first question is, which letter has neuronal cell bodies in the dorsal root ganglia? Well, it can't be A, because A is indicating the location of lower motor neurons, whose cell bodies are the large Nissl-stained structures in the ventral horn. So the question is, do the axons at B, C, or D have their cell bodies in the dorsal root ganglia? And the answer is letter C. The axons in the fasciculus gracilis, they are the central processes of the axons of neuron 1 in the dorsal column medial lemniscal system, and as such, they must have their cell bodies in the ipsilateral dorsal root ganglia. The cell bodies of B, the spinothalamic tract, are in the opposite dorsal horn, and the cell bodies at D, the corticospinal tract, are in the opposite motor cortex. Next question. Which has axons that cross the midline in the cord? And obviously we're dealing with the answer choice either being B, C, or D. Now the answer choice is letter B, spinothalamic tract, because as we just indicated, its cell bodies are over here in the dorsal horn, and their axons are crossing at every spinal cord level under the central canal to coalesce and form the spinothalamic tract. The axons at C never cross. Rather, the dorsal column axons synapse in dorsal column nuclei in the medulla, and the axon of the second neuron crosses at that point. And lastly, the axons at D, corticospinal tract, also cross near the spinal cord medulla junction. So our answers basically are C for the dorsal root ganglia. Axons of the dorsal column have their cell bodies there. And the axons that cross the midline in the cord are at B, even though the axons at D also cross. Question 2. Which of the following has caused this deficit? Again, rather than the exam describing what the deficit is, they could show you exactly where the deficit is in various visual fields. So the first comment we want to make about this deficit is that it is certainly homonymous, meaning that the deficits indicate a visual field loss in the left upper temporal quadrants of both visual fields. So because if it's homonymous, it must be a contralateral deficit, and that certainly would apply to choices A, B, and D that also involve some sort of right side lesion that's given us the left homonymous superior quadrantenopsia. All right, so let's be a little more specific. Let's rule out the obvious distractors. Number 1, a pineal tumor, even though it causes a form of a visual deficit, the deficit that is caused by pinealoma and Parinaud syndrome is a suppressed pupillary light reflex and a pineal tumor would have no effect on visual field loss. So C is not going to be a correct answer. If it were a pituitary tumor, the patient would have a bitemporal heteronymous visual field loss, not a homonymous one, as indicated in this particular picture. So that wouldn't apply. So C and E are certainly the distractors that are least likely to be the correct answer. So now our issue is, which one of the answer choices, A, B, and D, is the correct one? Let's deal with A first. A, if we had a complete right optic tract lesion, I would not have a left superior quadrantenopsia. I would have a left homonymous hemianopsia. So the deficits are not extensive enough to basically to correspond to a complete right optic tract lesion. Choice B, right visual cortex lesion. If it's in just the lingual gyrus of the cortex, I would have a superior quadrant defect as illustrated here, but I would also see macular sparing. And certainly in this visual field deficit as pictured, the macula is not spared. So the correct answer is a choice D, a right temporal lobe tumor that's compressed the fibers of the right Meyer's loop that are hooking through that temporal lobe on their way back to primary visual cortex. And if I have a lesion of the right Meyer's loop, I'm going to see the deficit as presented, a left upper homonymous quadrantenopsia. So the answer is D. Next, this patient is characteristic of some of the exam type questions where they show you a series of pairs of eyes and describe a patient who's attempting to, in this case, look in the direction of the arrow and has the disability that's illustrated above. So what is being asked of this patient is that they are being asked to look horizontally in the direction of the arrow, which is to the patient's left. And you'll note, based on that assumption, that they can abduct the left eye, but the right eye cannot adduct during attempted gaze to the left. So the issue is, where's the lesion? Well, first off, answer choices A and B cannot be correct because they are gaze control centers. So if I had a lesion in either A or B, neither eye could look in a corresponding direction. So if I had a left PPRF lesion, neither eye could look to the left. But if I had a right frontal eye field lesion, again, neither eye could look to the left. So the problem is only in this patient that the patient can abduct one eye looking left, the left eye, but they cannot adduct the right eye. So next, could the lesion be to the right oculomotor nerve? Well, certainly if I have a right oculomotor nerve lesion, I'm not going to be able to adduct the right eye, which is what we see in this patient. But what else will be seen? We would likely see atosis, which we do not see, and the diameter of the pupil on the affected side would be larger than the normal pupil. So basically this patient cannot have an oculomotor nerve lesion because we don't see the additional signs of ptosis and obviously a dilated pupil. Lastly, right trochlear nerve lesion really has very little to do with horizontal gaze because horizontal gaze is mediated by gaze control centers that facilitate firing of the appropriate sixth nucleus and the appropriate third nucleus. So the right trochlear nerve, basically, its major action is to allow you to depress the adducted right eye. So what is the correct answer in this particular case is a right MLF lesion. So this is an example of a patient that has right side internuclear ophthalmoplegia where they cannot adduct an eye and basically on attempted gaze, in this case, to the left. All right, question 3 is a cadaver view of or a cadaver brain view that's shown ventrally. And what's labeled on here, rather than in the schematic picture that we had in the notes, are the cranial nerves that are arising from various parts of the brainstem. So this is another way that exam questions can label cadaver nerves, in this case, cadaver brain nerves, and ask questions about them. For example, question A, patient burns their tongue on hot coffee but cannot feel the stimulus. So what they're asking you is what is disrupted that's providing a sensory innervation to the bulk of the tongue? And the answer is the trigeminal nerve is the major general sensory nerve of the anterior two-thirds of the tongue and much of the oral cavity, nasal cavity, and oral pharynx. So what we're asking you for is can you identify the trigeminal nerve basically on a cadaver brainstem? And the correct answer here is B, because as we said, the trigeminal nerve is the only true pontine cranial nerve arising in or out of the substance of the pons, whereas the other 3 pontine nerves, 6, 7, and 8, labeled C, D, and E, are arising from the pontomedullary junction. So the answer to question A is letter B, the trigeminal nerve. Next, question B. A patient here has a medially deviated eye. We're asking you, what's the lesion nerve? Well, if they have a medially deviated eye, that means they cannot abduct an eye on a corresponding side, and the lesion most likely involves the abducens nerve. So the answer to this particular lesion is letter C. There's the abducens nerve, one of the three nerves, including D and E, 7 and 8, that are arising at the pontomedullary junction. So now let's deal with question C. Question C refers to a lesion of the structure at the tip of the arrow. And since we're looking at a structure that's near the ventral midline of the medulla, the arrow is pointing to a medullary pyramid, which is a corticospinal tract. So corticospinal tract, when lesion, causes spastic weakness of the contralateral limbs. So the answer to this particular case is limb weakness. Horner syndrome, if affected, would be a lateral brainstem lesion, not a medial one. Loss of vibratory sense is possible in a medial medullary lesion, but the medial lemniscus is basically buried in the interior of the section. And loss of pain and temperature from the trunk would not be a possible answer because, like the Horner syndrome pathway, the spinothalamic tract courses laterally through the brainstem. In our next picture, again, we're showing a histologic section of the spinal cord. And the first point we want to make is, where is this section from? Well, note first that this spinal cord section has a very thin ventral horn, which means it's not in either the cervical or the lumbosacral enlargement, most likely at thoracic levels. And the reason we know it's thoracic levels is because of this pointed extension of the gray matter out here. That marks the location of the lateral horn and the preganglionic sympathetic neurons. So we know this is somewhere at thoracic cord levels, and our other criterion is to look up here and see whether there are one or two dorsal columns. And since there's a little fissure indicating a separation there, we have to assume that both dorsal columns are present, and the spinal cord section is from the upper thoracic spinal cord. So the point of our question is, which letter marks the lesion site of a patient that has lost vibratory sense from the leg? And we know that vibratory sense is one of the functional components of the dorsal column medial lemniscal system, but we need to distinguish which dorsal column it is, and we know if it's lower limb, it has to be associated with a lesion of the fasciculus gracilis, which is the more medial of the dorsal columns, as opposed to A, the fasciculus cuneatus, which is the more lateral of the dorsal columns, which is only carrying information from the T5 dermatome up, including the ipsilateral upper limb. Next picture, a ventral view of the diencephalon area, including the optic nerve, optic chiasm, the infundibulum that leads down to the pituitary, and the structures at A, which are mammillary bodies. So, in addition, we see the third nerve right there. There's the trochlear nerve. There's the fifth nerve because we're looking at the ventral aspect of the pons. So here's a classic way that the exam tests these issues. They'll identify a structure that's a component of a neurological disease or degenerative process and ask a classic, what else might we see in the same patient? So this picture, and I've already identified it for you, assumes that you know what A is and know that A is degenerating in a patient with thiamine deficiency that has Korsakoff psychosis. And they're asking what other brain structure basically is degenerating at the same time as the mammillary bodies. And the answer is the dorsal medial nuclei of the thalamus. Next, question B. Question B is labeling the optic tract. So don't confuse the cut optic nerves and the optic chiasm from the optic tract. So what we're asking here is, what would be the visual field deficit if we had a complete lesion of an optic tract? And the answer would certainly be, since we're past the chiasm, it would be a contralateral homonymous hemianopsia. So the answers are illustrated here. The dorsal medial nuclei of the thalamus degenerate along with the mammillary bodies in Korsakoff psychosis, and a complete optic tract lesion would result, as indicated, in a contralateral homonymous hemianopsia. Next question. Back to the spinal cord, and now we're looking probably at lumbar cord because, again, we have a large ventral horn at C, but it seems that like we have only a single dorsal column indicated by letter E, which must be the fasciculus gracilis. So the answer here is a lesion at which letter, thinking globally, would result in a contralateral deficit. And the only lesion structure in this picture that would result in that would be F, the spinothalamic tract, which is carrying pain and temperature from every dermatome beginning one or two segments below this particular location. All of the other labeled neural structures are ipsilateral in their basically their projection at spinal cord levels. The dorsal column is ipsilateral, and basically its cell bodies of that dorsal column are indicated by G. The dorsal column itself, vesiculus gracilis, is at A. The dorsal horn contains pain and temperature receptive neurons whose axons will cross, whereas C contains the cell bodies of lower motor neurons. D, the corticospinal tract, which basically is crossed but would not result in a contralateral deficit with any spinal cord lesion. And then B is the ventral root, which also would be an ipsilaterally projecting structure. So all of our major neural systems result in ipsilateral deficits if lesioned at spinal cord levels, except for the spinal thalamic tract. And what we're just talking about is a manifestation of Brown-Séquard syndrome. Next, first point we want to make with this myelin-stained section is we're looking at the brainstem. And the issue is what part of the brainstem? Well, it's got to be a part of the brainstem that has a large opening that separates the brainstem below from the overlying cerebellum. That large opening is the fourth ventricle. So it can't be in the midbrain because the midbrain only contains the cerebral aqueduct. And the issue is, could we be in the upper part of the medulla? If we were, we would see a very large and obvious inferior olivary nucleus, which is absent in this particular slide. So what we're looking at by default is a pons section. Pons section, fourth ventricle, and basically it has this fudge ripple appearance on its ventral surface that where we have lots of axons crossing the midline heading into a middle cerebellar peduncle. So the issue is, what are we looking at? We're looking at a region in the rostral pons where we have two trigeminal nuclei situated side by side right at the point of exit or entry of the trigeminal nerve. And those two nuclei found only at the point of entry or exit of the nerve are the main chief or primary or principal sensory nucleus of 5, which is what's indicated at the tip of the arrow, and the more medial placed nucleus under the tip of the white arrow is the motor nucleus of 5. So the answer is we're looking at the main chief or principal sensory nucleus of 5. Its function is to respond to touch modalities coming from trigeminal innervated cutaneous and mucosal territories. Next, now we've changed sections ever so slightly, and now we're looking at a classic rostral medulla section, because the space at the top of the slide, kind of V-shaped, is the caudal extension of the fourth ventricle, but what gives this away as a rostral medulla section is the prominent, highly convoluted inferior olive. And once we recognize that this is a rostral medulla section, you say to yourself, what cranial nerves and what other neural structures have to be here? And the answer is, since it's rostral medulla, we are in the territory of cranial nerves 9, 10, and 12. So actually the questions raised on here address exactly that issue. What axons are entering or exiting from the dorsolateral part of the rostral medulla indicated by the arrow? And the answer is the laterally entering or exiting axons have to be those of cranial nerves 9 and 10, because they exit dorsolateral to the olive, whereas the axons of the hypoglossal nerve exit medial to the olive between it and the adjacent medullary pyramid. So the identified axons are those of either the glossopharyngeal or the vagus. And in terms of what skeletal muscles they innervate, remember that those two nerves collectively innervate muscles of the palate, the pharynx, and the larynx, all of those skeletal muscles appropriately. Obviously, glossopharyngeal nerve only innervates one of them. The balance of them in the soft palate, the pharynx, and the larynx are innervated by vagal nerve fibers. Next is, this is a section through the caudal medulla, where we basically, as we indicated in our review, have axons of two neural systems that are crossing or are about to cross the midline of the brainstem. So first off, what we're looking at here down at the bottom, even though we don't ask a question about it, what we're looking at is the pyramidal decussation, the axons of the corticospinal tracts crossing. And just above that, we see indicated by letter A and B, which we're asking you to identify, the dorsal column nuclei. A is the nucleus gracilis, and B is the nucleus cuneatus, and you can see the terminal parts of each dorsal column coming up and synapsing in those respective nuclei. And very soon above this, even though we don't see an indication of it yet, we'll begin to see internal arcuate fibers emanating out of these nuclei that will cross to form a medial lemniscus. The other structure that we're asking you to identify is this very large nuclear structure out here. This is the spinal nucleus of 5 that represents second neurons that are part of a 3-neuron pain and temperature processing pathway in areas innervated by the trigeminal nerve. So our question was, and we pulled up the answer at the bottom, is where do those axons project? Well, since they are cell bodies of second neurons, they must cross the midline in the vicinity of their cell bodies and ascend to the ventropostural medial nucleus of the thalamus, which they do. Next picture is a horizontal MRI that's down near the upper part of the midbrain and also contains part of the vermis of the cerebellum as well as the temporal lobes on either side. So first off is we want to identify the structure at D. Tremendous clinical significance of D. D is the uncus. It's the most medial aspect of a corresponding temporal lobe that when there's increased intracranial pressure caused usually by a laterally presenting hematoma that compresses the lateral aspect of the hemisphere, that uncus will tend to herniate medially. And what we're asking in question D is, if it herniates medially, what is it likely to compress in terms of cranial nerves? Well, again, what we're looking at is the ventral aspect of the midbrain. It's upside down. The hole that's right there is the cerebral aqueduct. So classically, when the uncus herniates, it's most likely to compress cranial nerve 3 and initially present with a blown or a dilated pupil and later on with a ptosis and obviously an external strabismus. Our next question refers to a myelin-stained coronal section, basically that's going through the basal ganglia, hypothalamus, with some surrounding cortical tissue. So our first question deals with the structure at the tip of the red arrow. And the structure at the tip of the red arrow, suspended below the area of the diencephalon, is the optic chiasm. So simply we're asking about a picture that illustrates chiasm compression, and certainly the deficit that would be associated would be a bitemporal heteronymous hemianopsia. Next is, we're asking what condition might result in a degeneration of the structure at A. And this is a very good illustration of the fact that the basal ganglia are flanking, in this case, the anterior limb of the internal capsule. The anterior limb is this heavily myelinated fiber bundle that's illustrated here. The structure at A is the head of the caudate nucleus because it is medial to the anterior limb of the internal capsule, whereas the lighter staining structure at the tip of my arrow is the putamen, and medial to that are the segments of the globus pallidus. So classically, what degenerative disease results most prominently in loss of neurons in the caudate nucleus and an enlargement of the adjacent lateral ventricle? And the answer is Huntington's disease. And obviously, it would affect the caudate nucleus not unilaterally, but bilaterally. So bitemporal hemianopsia with a chiasm compression and Huntington's disease and the choreiform-like movements associated with bilateral degeneration of neurons in the head of the caudate nucleus. Our next picture, again, goes back to spinal cord. We've seen this picture previously, and all we're asking about A is what are the largest neurons in a spinal cord section that can be seen only in terms of their size with a Nissl stain. And as we indicated earlier, these are lower motor neurons, and classically, if you lesion the lower motor neurons, you're going to have an ipsilateral flaccid paralysis at the level of the lesion, emblematic, let's say, of a patient that has developed poliomyelitis. And our next picture is another horizontal MRI, but it's a classic one that's about the midpoint of each hemisphere, and it again includes diencephalic and basal ganglia structures. So first off, we're asking in this picture to identify what's at letter G. And before we identify G, note the significance of the relatively radiodense axons that are oriented in a V indicated by letters C and D. Those are axons that make up the internal capsule. So again, we're looking at B, G, and A that are neural structures containing neuron cell bodies that are situated either lateral or medial to the internal capsule. And certainly the structure at G, the largest lateral component of the basal ganglia outside that's lateral to the internal capsule, is the putamen. And The putamen basically has GABA neurons that participate in both basal ganglia pathways. So basically we're asking where those axons in G project depending on their basal ganglia pathway. So if they are in the direct pathway, they'll go to the internal segment of the globus pallidus. If they're in the indirect pathway, they'll go to the external segment of the globus pallidus. And last but not least is what is significant about the structure at E. Structure at E is primary visual cortex. So that lesion in a patient would result in a contralateral homonymous hemianopsia with macular sparing. So again, we're saying here if the axons in the putamen were in the direct pathway, they would go to GPI. If they're in the indirect pathway, they would go to GPE. And if you lesion primary visual cortex, again, the key element is, yes, you're going to have a homonymous hemianopsia contralaterally, but it must include macular sparing because of the dual blood supply of the macula. Our next question is a coronal section myelin stain through obviously cortical structures, diencephalic as well as basal ganglia. And again, for reference, look for large, heavily stained structures such as the posterior limb of the internal capsule. And we know it's the posterior limb because we have basal ganglia situated lateral to it, but what gives it away as being the posterior limb is we have thalamic nuclei medial to it, along with basically the body of the caudate nucleus. So what the question refers to is the structure at the tip of the arrow, which is one of three basal ganglia structures that's situated lateral to the internal capsule. The lightly stained structure that matches the intensity of the caudate nucleus is the putamen. Medial to that, in order, are the external segment of the globus pallidus at the tip of the arrow, which is the answer to the first part, and then medial to that is the internal segment of the globus pallidus. So we've identified the structure at the arrow, and we raise the question, where do axons from the globus pallidus external segment synapse? Recall that this is one of the neural structures in the indirect basal ganglia pathway, and their projection is to the subthalamic nucleus. So the structure is the external segment of the globus pallidus, and the indirect basal ganglia structure they synapse in is known as the subthalamic nucleus. Our next question refers to a myelin-stained coronal section through part of each hemisphere, the diencephalon, and the upper part of the brainstem in the area of the midbrain. What the red arrow is pointing to is one of the most distinct neural structures that is in the rostral midbrain. For reference, it is a collection of neuron cell bodies that are found just medial and above the heavily myelinated axons of the cerebropeduncles that contain, among other things, the corticospinal tracts. What the tip of the arrow is pointing to is the substantia nigra, and what we're asking is where do the axons at the tip of the arrow synapse, and they have a major projection into the caudate nucleus in the putamen in the striatum. So the major destination of those dopaminergic axons is a nigrostriatal pathway where they help enhance the functions of the direct basal ganglia pathway. Our next image is an MRI of the medial aspect of my mother's hemisphere, and that was taken 13 years ago or so when she had a slight hemorrhagic stroke indicated by letter J on this particular figure. But it allowed me to label a series of neuronal structures in this particular MRI and ask questions about them. For example, the first question deals with a patient that has a ptosis, a dilated pupil, and external strabismus, and asks which letter indicates the lesion site. So classically, this patient has the signs and symptoms of an individual with an oculomotor nerve lesion. And what we're asking you really is which letter marks the location of the oculomotor nerve. Well, we know that certainly the answer has to be in the midbrain, and the best answer has to be indicated by letter F. Second question is, patient has vertical gaze dysfunction and a suppressed pupillary light reflex. These are two of the signs or symptoms that are emblematic of a patient with Parinaud syndrome and a pineal tumor that's compressing the area of the pretectal region and the superior colliculus in the dorsal aspect of the midbrain. So in this particular case, the answer is M, because M marks the exact location of a pineal gland that sits, as we said, directly above the tectal area of the midbrain, just below the corpus callosum, and just in front of the vermis of the cerebellum. So let's indicate by identifying all of the other distractors that weren't answer choices. Letter A is the splenium of the corpus callosum that's affected in patients with a disconnect syndrome that results in alexia without agraphia. B and C are areas of primary visual cortex. B is the lingual gyrus. C is the cuneus gyrus. D and E are medial extensions of the pre- and the postcentral gyrus, respectively. D, primary motor cortex, that's a source of upper motor neurons that control the contralateral lower limb. E is a medial extension of the postcentral gyrus, where we have somatosensory representation for the contralateral lower limb. Letter F is the midbrain, G is the pons, H is the medulla. Letter I is simply the area in the third ventricle, probably in the area of the hypothalamus. Letter K is an area of the brain encased in bone. This is the area where we'd find the anterior and posterior pituitary and the sella turcica. Letter I represents the area of the third ventricle, and in its lateral wall would be the hypothalamus. Letter J is the posterior vermis of the cerebellum, the site of my mother's cerebrovascular accident. Letter K is the pituitary gland, probably both the anterior and the posterior pituitary, encased in the bone of the sella turcica. Letter L is covering a mammillary body. That obviously is a site of neuronal degeneration in patients with Korsakoff psychosis. Our next slide, back to a coronal section, is a question that refers specifically to the axons in the internal capsule. And we have to be careful about what part of the internal capsule this is, but we know what part it is because lateral to all parts of the internal capsule are basal ganglia structures, but only medial to the posterior limb are the nuclei of the thalamus, in addition to the area of the caudate nucleus. So definitely the thalamic nuclei are medial in this particular section. So this is the posterior limb. So we're asking what motor axons course through the posterior limb of the internal capsule, and certainly the best and virtually the only answer is corticospinal tracts. If we were in the area of the genu, then the answer obviously would be corticobulbar, but the genu would be an area of the internal capsule that would not be bounded medially by thalamic nuclei. Next slide, we have a lateral view of a cadaver brain with various gyri in the frontal, parietal, temporal, and occipital lobes labeled, and we're asking questions about where a lesion might be that in a patient that would have the corresponding signs and symptoms. Number one is, our first question is, patient has lower face weakness. Which letter marks a probable lesion site? So it must be a motor problem. So again, for orientation, before you answer this, make sure you orient yourself as to where the lateral fissure is. It's situated there, that's separating the temporal lobe from parietal and frontal, and that intersects very nicely right here with a very deep elongate central sulcus. And the central sulcus is important to this question because it separates a gyrus labeled AB, which is the primary motor cortex precentral gyrus, from a gyrus labeled CD, which is the postcentral gyrus on the anterior aspect of the parietal lobe. So patient has lower face weakness. It has to affect part of the motor homunculus. And what we're talking about is the corticobulbar neurons. Corticobulbar neurons are situated in the area indicated by A because the cranial nerve innervated area of the motor homunculus is situated closest to the lateral fissure. Next patient cannot look to the right with either eye. Where is the lesion site? What we're asking you to identify is where is the left frontal eye field. And as the name implies, it has to be in the frontal lobe, and the area at H is the area of the left frontal eye field, which when lesion would decrease a patient's ability to look to the right horizontally with either eye. In question number 3, patient has alexia and agraphia. And these are two of the signs and symptoms emblematic of a patient with Gerstmann syndrome, a lesion to the angular gyrus region of the dominant parietal lobe. In this case, the answer is letter I, which indicates that lesion location that corresponds to Gerstmann syndrome. So before we leave, let's identify the other letters which were not answers to our specific questions. Certainly, primary motor cortex, A was the area of corticobulbar neurons. The area at B probably represents upper motor neurons that are serving either upper limb or trunk muscles. C and D represent corresponding areas of somatosensory cortex, D for the face, C for the area of the upper limb or trunk contralaterally. H was the frontal eye field. The area at E is Broca's area, motor speech center. The area at F, primary auditory cortex. The area at G, Wernicke's area. I was certainly the angular gyrus. And J was back, constituting probably part of the primary visual cortex on the tip of the occipital lobe. And the answers obviously are here. A for the lower face weakness, H for the frontal eye field, and I for the area of the lesion that constitutes Gerstmann syndrome. Next, kind of an integrated embryology-related question. That is, again, we've labeled spinal cord structures in here, and we're indicating that this patient has fewer neural crest cells than normal. And we're asking which of the following labeled structures will have fewer axons than normal because they're all derived from outgrowths of neural crest cells. So the best answer in this particular case is the dorsal column. Because remember that the dorsal column, indicated by letter E, are the central axonal processes of dorsal root ganglion cells that I'm encircling on the outside of the spinal cord section. So if I have fewer than normal dorsal root ganglion cells, I'm going to have fewer axons in a dorsal column. All of the other neural tract structures, particularly those to a D and F, basically have their cell bodies derived entirely from the neural tube that are found inside the CNS, and obviously they would have no depletion of axons in a patient with fewer neural crest cells than normal. And again, A and D are neurons that develop basically in the gray matter of the CNS, would be unaffected by neural crest cell disorders. And B represents the ventral root. Ventral root axons in B arise from lower motor neurons in C, or arise from preganglionic sympathetic neurons in the lateral horn or sacral spinal cord levels. And lastly, our next question is, which letters are sites of degeneration that would occur in a patient with amyotrophic lateral sclerosis? We know that this patient has a bilateral upper and lower motor neuron degenerative disease. So what we're asking you here is a patient with ALS will have degenerated axons in D in the corticospinal tract, as well as neuronal loss in C in the lower motor neuron cell bodies of the adjacent ventral horn. So here are the answers. Dorsal column represents the central processes of axons of dorsal root ganglia, neural crest cell origin, whereas patient with ALS will have degeneration inside the spinal cord at D and C, and obviously they will also lose some axons of the lower motor neurons, also shown by letter B, which is the ventral root.